So a very good afternoon and good evening at I think good morning in France and very good afternoon in India. Uh, Today we are having a very special guest and an eminent speaker for one of the chosen topics. So before going ahead with the topic, you might be seeing what is the topic all about, and we need to have a little bit of introduction why we have chosen these topics. You might be listening and seeing to our webinars, and this is our sixth webinar, and thank you so much for your appreciation that you put every time when you come and join with us, ask your queries and questions. Our previous webinars were depending more on what exactly the modality or the protocol should be there for diagnostics of the COVID-19 infection, because it is a newer infection which nobody has been known since last many years. So that is why on a very lighter note I had put it was my miscellaneous chapter, and hopefully it shouldn't be only mine, it may be a miscellaneous chapter for most of the diagnostic and the healthcare professionals across the globe, because it used to be at the later on pages of our textbooks where it was only given into 2-3 pages. Okay, this is some of the virus which can be there, it may cause a little bit of illness. But interestingly, there was one report in 2007 which said there is a severe acute respiratory syndrome coronavirus as an emerging and a re-emerging infection. I don't know how many of you might have seen this report, but yes, today it has become a fact and it is a truth that we are having a pandemic situation with this miscellaneous chapter virus, which is called as the coronavirus, which is there. What exactly we have been looking from the last previous so many days of this lockdown situation, and from the till the time of outbreak from 2019 November December till 2020, we are here in the middle of April, and we are still trying to figure out what could be the reasons why people are dying. And it was written in the books and the literature, it just causes a very simple flu like syndrome. But is it the reality or is it the truth, or haven't we read more or have we known the details about it? The whole fight is not now only on the diagnostic protocols, but yes, there is some other protocol which we need to understand as the medical person or as healthcare professionals. So basically, when I was going through the literature and when we were thinking, okay, we have done a lot about the RT-PCR is the reason we are still awaiting for the antibody screening test to happen for surveillance. But how are they going to come out unless and until we know what is an immunological background behind this particular infection, which we have never been read about it, and we don't even know what is the type of immunity which is what we are going to get for a longer time or for a shorter time. So is it like how our immune system fights against COVID-19? Why some COVID-19 patient crashes so badly and they go into the mortality rate of like which is reported around 3.5 to 5%? Will there be ever be immunity towards COVID-19? And a bigger question lies still dead across the globe is, will there be a vaccine or not? So all these questions probably we may not solve it at this particular time or in this particular topic, but to have a certain level of discussion on this topic, we want to understand how do we map the immune responses or the immunological response towards COVID-19 infection today. So for this, I have an honor and privilege to call upon our one of the international guest speaker from France. He is Dr. Franck, Associate Professor in Immunology at University of Montpellier. He is a bachelor and master's degree in biochemistry, postgraduate in immunology and anti-infectious immunity. He's done his PhD from USA and he's specialized in the mucosal immunity and developed experimental mouse model for Crohn's disease as well as Toxoplasma gondii. Going more ahead, he has almost had around more than 70 international publications. He has been award winning for his PhD thesis. He holds currently a research position as well as a teaching position in the University of Montpellier, where he trains the masters, the graduate, and the postdoctoral or the doctoral students in the field of immunology, epidemiology, and microbiology. And more so, why did we choose an immunologist for this session? Because we have been looking for somebody who can throw a detailed light about the immunological responses regarding this particular infection, as very less has been understood. His expertise still lies in the field of immunology. He has also developed vaccination research tools for adenoviruses. When I had gone through his credentials, it is like I was very much, very happy to see somebody who has done a lot of his job and work in the field of virology. So without wasting much of his time, I would like to call upon Dr. Franck to start with his presentation. Dr. Franck, over to you.
Hi, thank you, Dr. Prakash. I'd like to thank you very much for this invitation. I'd like to thank also Franck Segui. And I would like to say hello to other people in India. Thank you for being here. And also to my students in Montpellier, in Nîmes, and also in Tlemcen, in Algeria, if they're here. Thank you for coming. So I'm going to talk about COVID-19, and my title might be a little bit tricky. I'm just going to go to the current situation and try to ask very important questions that many people are asking. And also, of course, I'm going to talk more specifically to the cytokine storm that's involved in some patients who crash sometimes during when they got COVID-19. So the severe acute respiratory syndrome coronavirus 2, called SARS-CoV-2, is a single-strain RNA virus responsible for the coronavirus disease 2019, called COVID-19. And the disease was first identified in December in Wuhan, China. That's why sometimes we call it Wuhan virus. And since it's sweeping the world with the epicenter that starts in China, and then right now it's in Europe, but in the States, in the United States, it's worsening a lot. We have, this is numbers from tonight, we have more than 2.5 million of people confirmed positive for the disease, and almost 180,000 deaths worldwide. So the first question is, what is the real mortality rate? So this question is hard to answer because these numbers are fluctuating. It depends on the countries we're talking about. For example, in Belgium right now it's very high. It's also high in Italy, in France also, but it's lower in Germany for some reason. It's lower also in South Korea. So there is many reasons for that we can go through. But today, the estimation is between 1.8 to 3.4%, and the WHO, the World Health Organization, estimating about 3.4% the mortality rate. So there is a discrimination between the male and the female. Male are more susceptible to the disease comparison to the females. And something very important, if you look on the right, you have most of the people who got infected are between 10 years old and 60 years old, but the people who are dying usually are older than 65 years old. If you look at the mortality rates with people aging, which are older than 80 years old, it goes up to 90%. Fortunately, the kids are spared relatively, and for the people between 18 for adults and middle age, this mortality rate is around 4%. If you want to compare it to the Middle East coronavirus or to the previous epidemic, Middle East coronavirus was about 34%. It was very deadly. The SARS from 2003 were also very deadly, 10%. But if you compare to the flu is between 1 and 0.2%. So it's more deadly than the flu. But if you look at the famous R0, which is the basic reproduction number, it's between 2 and 3. That means one infected people could infect about three other people. So you have also to know that for more than 85% of the population in the world, COVID-19 is not very severe and you survive to the disease. But for 15% of the case, it could be a big problem, especially if you are among the people with comorbidities, if you have obesity, what's happening in the US or in Egypt right now, cardiovascular disease, diabetes, chronic respiratory disease, or hypertension, or even cancer. You are among this population with what we call high risk of developing a severe situation with this disease. So next question, and my students from Nîmes are going to be happy about that. what are the percentage of asymptomatic infected people? What Sir Basil Henry used to call the fog of the pandemic. That means this is the number of people which carry the disease but don't know it and might be a source for the contamination. The first numbers were quite high from China or from Italian. We believe that between 70 and 80% of the population were asymptomatic and represented consequently a formidable source of contagion. But if this is true, then why the hell are we locking down? Because if everyone is infected, in that case, what's the matter? So if you want to be more reasonable today with the accurate tests, even if it is the beginning, so we don't know yet for sure, the CDC in the US believes that around 25% of the population, of the infected people, are asymptomatic. And there is a very recent study made on the performance of the Diamond Princess cruise ship. This boat with almost 4,000 people, everyone were tested. And if you believe this study, it's around 20% of the affected people we are symptomatic for the disease. So I think it's more reasonable numbers. But if you want to keep the facts, we don't know exactly. It's between 5 and 80% of the affected people which could be asymptomatic. If you compare to the Middle East coronavirus, the asymptomatic affected people were between 0% at the beginning of the disease to almost 30% at the end. And for the flu, it's between 5 and 35%. It depends on the strain. Then, do COVID-19 survivors have immunity from reinfection? That is also a very tricky question because we don't know. And today there is some question because some people who survive to the disease might have a reinfection, but we don't know if it's really a reinfection or not. Maybe the virus were dormant and came back later. The patient was not cured completely. So what we know from previous studies is that specific antibodies from survivor of the previous SARS outbreak in 2003 are protect against the reinfection and with a long-term immunity that lasts up to 3 years, which is not a lot, but it's enough. And from animal experiments, specific antibody protected monkeys. It's a very recent study that had recovered from COVID-19 from beginning reinfected. So this is positive, but actually the WHO official said it's unclear whether or not patients who recover from the disease are protected or not. For sure, we do have an immune response. Is this response very protective? We don't know yet. Well, my guess is we are protected for most of us. And is the SARS-CoV-2 mutating? Also, it's interesting because if the virus is mutating, that means we can forget about the vaccine. But fortunately, to my opinion, we are in good situation. So there is a recent study. It was a phylogenetic analysis on COVID-19 strain. About 3,000 strains were collected all over the world. And the study showed there is right now 3 central variants of the virus called A, B, and C. The A strain was the one that we find on the bats. So the bat was supposed to be the reservoir of the virus. I know there is some studies, especially in India, that said that the bat is not the reservoir, but I'm not going to go further on that topic. It will be a matter of debate later. The B strain, it's a strain you find in China at the beginning of the outbreak. And the C strain is the strain you find mostly in Europe. So it's interesting to study this strain because you can have guess the circulation of the virus, go back and forth to continent or to countries. But at the beginning, observation provided evidences that the genetic diversity and the rapid evolution of the disease, of the virus. But actually, it's not really mutation, it's more an evolution. It's a normal evolution of the virus among the population during the spreading. So apparently, SARS-CoV-2 seems to mutate about 4 times more slowly than the flu. And as the outbreak unfolds, we expect to see more and more diversity, of course. And we have to be careful because mutation can reveal how the SARS-CoV-2 moves, but they're also very easy to over-interpret. So far, I think the signs are good about making vaccine in the, I hope, the near future. And so what is the current situation in India? So Dr. Prakash, you stop me if I'm wrong. I believe the first case of COVID-19 pandemic in India was discovered in January 13. In March 33rd, India lockdown. I guess it was a week after France. So at April 2020, so tonight, about 20,000 confirmed cases in India, more than 600 deaths, and a case fatality ratio around 3.2%. So of course it's too many deaths, but compared to Europe, actually it looks like that India, exactly like sub-Saharan country, actually are controlling the disease a little bit more better than India or United States. So we can discuss about it. There is many reasons for that. Maybe the virus virulence it's going down. Maybe the temperature help to slow the disease. Maybe the average age of the population, which is around 28 years old in India, makes a difference. We don't know, and I'm not going to discuss further. So in March 13th, the India Council Medical Research published full genome sequence of the first 2 SARS-CoV virus from India. I think India was the 5th country in the world to publish a full genome of the virus, so congratulations. Rajasthan became first India state to conduct COVID-19 rapid tests, and India plans to significantly increase the COVID-19 screening capacity. That is good news, actually. But, because there is always a but, part of the population of India has tuberculosis, about 2.8 million. And a lot of people have respiratory issues associated to high rate of smoking and air pollution in India. That means a part of the population is going to be at risk and potentially very susceptible to the disease. So to my point of view, there is still some concern about COVID-19 in India, and I think COVID-19 is still a big threat for this population. So about the diagnosis, what to do and how, I'm going to go very quick about that because I guess most of you know, so especially the medical doctors. So the control of COVID-19 relies primarily on countries' public health capacity, meaning detection, prevention, surveillance, and treatment. Because there is no current treatment very efficient so far, and because we cannot fight a fire with our eyes blindfolded, the WHO has called for the country to test any suspected case. So remember what the head of WHO said to us. He said, we have a message to every country: test, test, test. So the WHO strongly recommended COVID-19 diagnosis with combination strategy, meaning you have to use 2 strategies to be sure of the diagnostic. So the strategies we are using are molecular diagnosis and serological diagnosis. So by qPCR and by ELISA or quick tests. However, if high-quality diagnosis technology are available for SARS-CoV-2 in most developed countries, they are neither sustainable, accessible, or affordable in low-income countries. So in this graphic, you can see basically the virus load in blue. You see that you get contaminated, and after 5 days, you got the first symptom, and the virus is going up until about 2 weeks. And from 2 weeks, the patient begins to recover in a good scenario. And after 28 days, you cannot see the virus anymore. So even after 2 weeks, it's sometimes very difficult to detect the virus. So you can detect the virus very early, few days after the infection, until about 3 weeks. So at 7 days, the IgM, the primary IgM are going to go up, and you can detect them about and about 10 days after the infection, about a week after the first symptoms, and then going down after 3 weeks. And IgG are coming after 2 weeks, or are detectable probably after maybe 12 days after the first symptoms. So meaning you have to adapt the technology of diagnosis. So the first technology we used is qPCR. So apparently it's a gold standard to detect the virus. This is how you know that you are infected, because you did find the virus in your body. So the advantage of this technology is you can do early diagnosis in patients which are shortly hospitalized, just after the first symptoms. And for example, sometimes you don't see any antibodies, but you can detect the virus by PCR. And also, it's an adapted open system. That means if you have equipment, you can use any kit to detect the virus. The disadvantage, it's sometimes complex, it's expensive, you need equipment, at least you need a PCR machine. It takes any steps, and people who use that have to be formed on the technology. And also you can have the numbers we have in France. It's about 20% of the sick people affected by the virus are negative in PCR. That means it's about 20% of false negative. And mostly is because the specimen sample collected. So the second test, it's a serological test. So we can do by ELISA, but this is not ready right now. But people develop a quick IgM, IgG detection test. So you can see people negative, IgM positive. That means you got infected very recently. IgG positive. That means you get infected a long time ago, a few weeks at least. And if you have IgM or IgG, you are in the middle of the infection. So if you look to the numbers, it looks very specific and very sensitive, but actually it's not so reliable. The good point, it's low cost and quick. For example, the BioSynex technology, this is a kit that some colleagues are using in France. They say it's very quick, it's very cheap, actually, €8 for one test. And it's very interesting for patients for which the viral load is undetectable. For example, if they are late in the disease. And also, for example, it's interesting for patients under investigation. That means if you are in the airport and you have travelers coming from I don't know where, you can check very quickly if the patients and the people, you can have an idea on his history of the infection. The negative part is despite number of tests on the market that not always reliable. So this is what we saw in France. It's not so efficient as we believed, but they are getting better every day. People are working a lot on this system. And you can look at least minimum of 5 days after the first symptom. So, clinical and biochemical feature of the disease of COVID-19 patients. So, you know that the disease virus is targeting the respiratory system, the lungs. But there's already some evidences that COVID-19 can cause damage to tissue different than the lung. For example, almost 40% of the people had neurological manifestation. 50% of the patients have arrhythmia, acute heart injury, impaired renal function, and abnormal liver and when they arrive to the hospital. So this is a very shitty virus, actually. What are the clinical features? This is a study from a patient in Wuhan, about 41 patients. And on the right, this is a meta-analysis from at least 10 studies on about 2,000 people. So as you can see, the major symptoms of the disease are fever in 90% of the case. The fever goes from 38 to more than 40 degrees sometimes. Cough, malaise and fatigue, expectoration, dyspnea, that means difficulty to breathe for 20% of the patients, and minor symptoms such headache, dizziness, diarrhea, nausea and vomiting. And of course, you have to check the bioradiologic evidence of pneumonia A, but not in the very beginning of the disease. So what are the laboratory examination? So there is major factors that involve when you get the virus. The one we find more often is lymphocytopenia. That means a diminution of the number of the percentage of lymphocytes, not leukocyte, lymphocyte, in 35 to 80% of the people. This is a meta-analysis made on 5 studies, and also in between half and almost 90% of the people, is dependent on the studies, you have an increase of C-reactive protein called the CRP. You have in 30% of the people, about a third increase of lactic dehydrogenase, LDH, and you have leukocytopenia in 30% of the people. And some minor observation, you have hypoalbuminemia, thrombocytopenia, increased creatine kinase, and increased ferritin, and sometimes IL-6. So LDH is measuring, reflecting the tissue suffering. Albumin is measuring the liver and the kidney dysfunction, and creatine kinase could be the heart of the liver. So one very interesting study, one of the first one, was looking at the CRP level. And the CRP is not specific, of course, to COVID-19. The CRP is correlated to the level of inflammation, global inflammation of the body. And its concentration level is not affected by factors such age, sex, or physical condition. So in this graphic, you can see that they compare between patients that are mildly affected, not mildly affected, but with mild symptoms, moderate symptoms, severe symptoms, and critical symptoms, probably patients in critical care units. So you can see there is an increase to the CRP level according to the severity of the disease, but also to the lesion in the lung. So CRP level were positive correlated with the lung lesion and severity of COVID-19. So in the next graphic, this is quite interesting here. You have the people studies the quantity of lymphocytes, the quantity of albumin, the percentage of lymphocyte, the quantity of CRP in the serum, and the percentage of neutrophil. And what I find is if they correlate these factors with the CT value of, just for my students, sorry, for the others, the CT value of the virus, it's reflecting the viral load. That means if you have a low CT value, you have a high quantity of virus into the blood, because the CT means cycle, and that means the virus were detected at low cycle during the PCR test. So the percentage or the quantity of lymphocytes, also the rate of albumin, were negatively correlated to the quantity of virus, but the CRP and the percentage of neutrophil were positively correlated to the viral load. This is a study performed by a friend of mine, Christian Sietka, in France. This study is showing the quantity of lymphocytes and the concentration of CRP in patients affected with non-severe coronavirus 19 and patients affected with in critical case. And you can see that this study was performed on 10 studies from China. Globally, for every studies, the number of lymphocytes is decreasing with the severity of the disease, and the rate of CRP is increasing globally for every studies, and increasing according to the severity of the disease. So the last study is, I believe, very interesting. Is showing you the correlation between the CRP level in the blood and the age of the patient. And this graphic shows you that older people have higher CRP level, which makes sense because older people are more susceptible to severe severe situation of the disease. But something to me was even more interesting, but I won't explain very much because it's going to take a long time. It's the CRP level is correlated to the level of neutralizing antibody against the virus. So it's very surprising, but very interesting in terms of fundamental immunology in order to understand the natural history of the virus infection. So I'm thinking about antibody-dependent enhancements, but of course, we can talk about that later if you want, but I'm not going to go any further. Well, so could additional tests like CRP or the counting of lymphocytes decrease the false negative rate by RT-PCR? For sure. It's not going to tell you you got adenovirus infection, but it's going to help for the diagnosis, especially for the severity of the disease. So the guidance from Chinese, Italian, England, from the King's College Hospital, and the CDC recommends testing CRP and procalcitonin. So why procalcitonin for my students again? Because this factor is not supposed to increase during viral infection, but during infection by a bacteria only. So if you got coronavirus, you should have normal PCT and elevated CRP. But if you have, for example, co-infection, you could have also increase of procalcitonin. So they also recommend to test CRP for disease severity and also lymphocyte count, L6 and IL-10 testing. I'm not so sure about L6. Also, they recommend the chest X-ray. What's the World Health Organization guidance? Actually, they're like Switzerland right now. They recommend performing routine hematology and biochemistry laboratory testing, so not very useful. Well, so now let's go to the real topic of the seminar, the cytokine storm. So what is it? Of course, why people are dying from COVID-19 infection? Because of respiratory failure, most of the time. That is called also ARDS, for acute respiratory distress syndrome. This is the leading cause of mortality. People are dying because they cannot breathe anymore. But patients with critical illness sometimes have high plasma level of inflammatory markers, suggesting potential immune dysregulation. And in some patients only, severe cytokine storm is observed. And it's also an important cause of death among the people who goes to severe disease. And this situation is called cytokine storm syndrome, CSS. So I just remind you that for 15% of the case, of the confirmed case, the patient are going to progress to severe phase. So on the right, let me explain to you. So you have on the right a situation where most of the people, 85% of the people, are going through. So you get infected, and you are going to develop immune response because the body is fighting against pathogen. So you are going to produce type 1 interferon because type 1 interferon it's the cytokine against the virus. This is how we protect ourselves for years and years against the virus. And this type 1 interferon is going to induce the production of cytokine and chemokine, infiltration, recruitment of inflammatory monocyte, macrophages, dendritic cells, neutrophil. And later on, you are going to trigger optimal adaptive immunity with optimal T cell and antibody response from B cell, an effective virus clearance, a protective immunity, hopefully, and also survival, and you survive to the disease. But in 15% of the case, it's not going to be like that. So the virus is coming, is robustly replicating, and you have a delay of interferon response because coronavirus have something in common with Ebola, with the avian flu. They can interact, they can evade the immune response, especially by targeting the interferon response. And most of the coronavirus are going to delay this interferon response. So, meaning, I'm not going to explain in details, but in the end, you're going to have a very high inflammatory response, with a massive infiltration of monocyte, macrophages, and neutrophil, and consequently suboptimal, so problematic T cell response with a suboptimal antibody response, impair various currents, and then acute lung injury, and leading to acute respiratory distress syndrome, and eventually death. So this slide is very crowded, sorry, but it's actually very easy to understand. This is a basic of immunology response against the virus. So you get infected by the virus. The virus usually goes to the lung and is going to infect epithelial cells in the lung through a specific receptor, which is AC2 receptor. So with this spike protein. So the virus goes to the cells and then get detected eventually by what we call the PRR, and this receptor very conserved. And my guess, if you have to compare with other coronavirus, this PRR seven, 8 or 9, which are intracellular and which are specialized to recognize RNA sensor, because it's an RNA virus. So your body is going to respond, so produce chemokine, cytokine, the macrophage are going to do phagocytosis, and eventually the APC, the antigen-presenting cells, are going to produce cytokine and to present specific peptide, specific antigen, to T cells, which are going to involve in Th1 process. So Th1 is for intracellular pathogen like virus, and also activate the CTL response, the cytotoxic T lymphocyte response, the CD8. But this Th1 also with the T follicular cells, because here on the picture it was Th2, but I'm sure it's not Th2. And there is a paper in Nature Medicine who show that for people who recover very quickly from the disease, this is mostly T follicular that is responsible for efficient production of antibody response in affected patients. So normally, this immune response is followed by a normal expression of cytokine. But sometimes, if the cytokine is too high, the production is too massive. In that case, you can have what we call the cytokine storm, which could be a disaster for the lung, but also for other organs. And because there is a lymphopenia in people in severe situation, we believe that the cytokine storm, which can become pathologic, come from mostly the natural immunity, such macrophages, NK cells, neutrophil especially, and maybe dendritic cells. On the next slide, this is an experiment performed in 2016, so before the current outbreak, and the previous coronavirus. So this is a mouse model, so it's an animal model. And what the author did find in these studies, if the SARS, the coronavirus, infects you, the SARS is going, as I said, to delay the expression of type 1 interferon. So because interferon is production is delayed, you're going to have a huge infiltration and a strong production of cytokine in the body, which is going to lead eventually to disease, so inflammatory response and impaired T cell response and lung injury. So what they find, if you treat at the very beginning of the infection with type 1 interferon, you can rescue the mice from the disease. If you block type 1 interferon here as the second phase, the late phase, if you block the infiltration, if you block the inflammatory response, the cytokine and chemokine, you rescue eventually the animals from the disease. So according to this very interesting study, if we die from coronavirus sometimes is because of too little and too late expression of type 1 interferon. I think this experiment is quite interesting. Let's go back to the human system. So basically, during the early stage of the disease, so meaning during the incubation period and the non-severe stage of the disease, you are going to build efficient immune response. And at the end, you are going to clear the virus and recover from the disease. But this is going to happen in hosts that are, in theory, in good general health and in appropriate genetic backgrounds. In 15% of the patients, for example, with comorbidities or people with can go to the severe stage and of the disease, and in that situation, the cytokines release syndrome affect patients with severe condition only. So this is very important here, because that means if you want to help the hosts to fight against the disease, during the early stage, you need to boost the immune response. So at the very beginning of the infection, you need to boost the immune response, for example, with a treatment with type 1 interferon. But during the severe stage, it's the opposite. You have to block the immune response. That's why we use corticoids sometimes, or maybe anti-TNF-alpha to block the response. So this is very important to know that according to the stage of the disease, you have either to boost or to block the response. So the cytokine storm now, what is it? So I'm sorry, but for immunologists, this slide is very easy to understand, but it could be a bit harder for the one who don't know the cytokine and chemokine. But I try to be very clear. So if you compare with the influenza, for example, H7N9, which is the avian flu, a very dangerous, very lethal disease, people find in the serum a lot of IL-6 and a lot of gamma interferon, meaning the body is starting to fight with Th1 response, but also with high inflammatory response. If you look at the regular flu, like H1N1, if you compare the cytokine storm between mild patients, hospitalized patients, and critical patients in intensive care cure unit, you can see that for people with low symptoms and in mild situation, you have a cytokine called IP10 or CCL10, the same name, also NCP1 and MIP1 alpha. So it's mostly chemokine here. For more severe case, you got type 1 interferon, gamma interferon, type 2 interferon, sorry, and TNF-alpha. So it's going to be more serious, and patients are going to trigger Th1 response with also high inflammatory cytokine. But for people in critical situation, because everyone, there is about maybe 10,000 deaths a year of flu in France, for example, people increase the concentration of IL-15 and IL-6 in the body. If you compare with previous coronavirus, like the Middle East coronavirus or the SARS in 2003, both have IL-1, IL-6, IL-15, IP10, and gamma interferons. So this is kind of similar to the flu. And the cytokine storm is not only for flu or coronavirus. You can also see for dengue, for example, infection, or Zika infection. But there is a big difference between this actual coronavirus, COVID-19, and the other virus, the flu, for example. It's for SARS-CoV-2 patients who did not experience complications, so they did not experience any problem of respiratory failure. Only minimal pro-inflammatory cytokine and chemokine were found in the serum, even when the patient was symptomatic. And this is a big difference with the flu, because with the flu, everyone got cytokine and chemokine in the serum. For the COVID-19, apparently, if you have a not severe form with no respiratory complication, you don't see any cytokine and chemokine in the serum. So now, for the last two slides, let's go to the eye of the cytokine storm. So this is gathering of data outcomes I find from 3 different studies made in China for all of them. And they did compare the cytokine storm from healthy donor, so people who are not infected, from infected patients, and from infected patient in a critical situation, so most of the time in intensive care unit. So if you look for the 3 groups, you have cytokine and chemokine who do not change at all. For example, IL-5, IL-12, and IL-15. And this is also very different, because if we remember well from the previous slide, IL-12 and IL-15 was very high for people in critical situation with the flu, but it doesn't move at all with coronavirus. If you compare with the infected people in both situations, mild and in critical situation, if you compare to the healthy, you have an increase of a lot of chemokine and cytokine, L1 receptor agonist, gamma interferon, L4, L8, IP10, CCL2, CCL4. So I'd like to point out the fact that you have also IL4 and gamma interferon. And IL4, it's a Th2-related cytokine. And this is not the case for the previous coronavirus. You never find any IL4 in the body. But for this one, you have a little bit of IL4. I guess it's probably because the body wants to, I don't know, maybe counteract the Th1 response, fight the infection. And if you compare the infected people in my situation to infected people in a very severe case, you have IL-2, IL-7, IL-10, IP-10, CCL2, and TNF-alpha. So the cytokine which are underlined are the ones that are upregulated in at least 2 of the studies here on the 3 that I looked on. Well, but there is another study. This one was performed on 41 patients, and they did look more than 50 cytokine. And what they find, actually, is that if you compare from the healthy donor, the healthy patient to the infected one, they did find gamma interferon, L1 receptor agonist, L6, L10, CCL7, CCL3, and or again IP10. And this is a cytokine which are common with all the studies performed in this during this talk. But the only cytokine find in common with all the studies for people in a very severe situation was IP10. This is the only one I find in common with everyone. So that was in the serum. In this last studies, they look 2 different groups. The people in very severe case who survived to the disease in comparison to the people who did not survive to the disease, so died one. And they find for the people who do not survive, undetectable, so no concentration of L1 beta, but they did find a lot of IL6, IL8, IL10, and TNF-alpha. So IL10 and TNF-alpha apparently are also very important for all the studies I find and are probably reflecting the critical situation and maybe a good marker for death prognosis. And finally, all the studies were performed in the serum. They look in the serum, and these studies look directly in the lung. So they collected bronchoalveolar fluid, and they look at the chemokine and cytokine expression and compare infected people in severe situation to people in less severe situation. As they did find also IP10 expression and MCP1 in these fluids. So to sum up, actually, the cytokine storm syndrome is not for COVID-19 diagnosis for sure, but it might be a very good markers to evaluate COVID-19 severity in some patients which are in respiratory distress. So to me, if I gather all the information I had on this paper, if you look on hospitalized people, so this is just people in critical situation, people need to be hospitalized. SARS-CoV-2 infection increase gamma interferon, IL-10, CCL7, CCL3, and IP10. And IP10 apparently is very important. For people in very severe case with death prognostic, you have IP10 and TNF-alpha. That's why maybe anti-TNF-alpha will be a good treatment solution. IL-6, I'm not sure because there is some studies who found that IL-6 was very highly expressed, but in other studies, they said IL-6 was not detected at all. So it's very hard to have a conclusion right now. I think it's too early for IL-6. I'm not sure IL-6 treatments, clinical treatment right now works either. So in conclusion, COVID-19 caused Th1 inflammatory cytokine storm in some patients with severe case that leads to acute respiratory distress syndrome or extrapulmonary multiple organ failure. So it doesn't target only the lungs. 6CL10 or IP10 and TNF-alpha could be, to my opinion, very good key biomarkers, both in the serum and in the bronchoalveolar fluids for COVID-19 exacerbation and death prognostic. That's it. I'm finished. I hope I was clear. I would like to thank you very much to be here today, and I'm open for any question you have. Thank you very much. Be safe.
Yeah. Thank you so much, Dr. Frank, for putting and throwing light with the details into the cytokine storm, which is what we have been reading and learning a lot about it. But actually, what is happening, we don't know. We are trying to understand the multiple dimensions of the disease in at one particular level, whether the diagnosis is the right way of going ahead, or whether the prognostic markers, or whether the screening or the monitoring markers are the way to go ahead. Probably, I think there were few more many questions which were there, which were situated around. Very interestingly, I could find a question which I had bucketed in one plate itself. It was relating what is this infection is different for the different type of blood groups available, or is it like the severity of infection is different with different blood groups, or blood group O is more protective against this infection?
Yeah. I know it's very interesting question. So I guess there is genetic susceptibility, but so far it's too early to say. But you know, Dr. Prakash, as well as me, that for example, for HIV, we have some genetic susceptibility for the flu also, and it is mostly related to HLA. For the SARS, for example, we know that the people susceptible to SARS are mostly people with HLA-A31, and this is a haplotype of HLA, which you can find mostly in the Asian population. So we don't have any answer about the susceptibility, but for sure there is some difference between population. For example, if you vaccinate people in Europe or in Africa, the kids are going to have higher response in Europe compared to Africa. Could be the genetic, it could be also the way of life, but we have a lot of difference between population. So in terms of mortality rate, we don't know yet because there's many factors. But I guess we're going to find soon HLA susceptibility for this particular disease.
So thank you so much for this question. One more question is very interesting. I mean, when I look back into the theories and what I could see and sense about the audiences, there have been a question when the infection came into picture. Is it like, are we dealing with an hyperimmune response, or are we dealing with type 2 hypersensitivity? Because at the same time, you told very rightly, at initial cases you need to boost immunity, but at later cases you need to even decrease the immunity at certain levels. So which is a very paradoxically contradicting, and it's a tedious task for a physician to do two things at one time.
Yeah.
Right. So what is your take on this? Whether it is hypersensitivity or is it hyper?
No, I think it's not hypersensitivity, but okay, you have to discuss more about that. I think it's a matter of time. If you, for example, if you take type 1 interferon is very tricky. Type 1 interferon involved in autoimmune disease like lupus, for example. Too much type 1 interferon is going to induce inflammatory autoimmune disease. But it's also a cytokine that used to be used to treat multiple sclerosis, to stop the inflammatory. So same cytokine, sometimes it's anti-inflammatory, sometimes it's pro-inflammatory. So it's difficult to answer, but to my opinion, it's not hypersensitivity. It's that the immune response are going for some reason to be uncontrolled, and once you pass a certain point, there is no way you can control this immune response. You have non-retour time point, actually. No, so it's difficult to answer here.
Okay, and there was one question. I don't know why this question has come up, but again and again, there was the question. I will put it into one. One is, are male more affected than female? Because I think the audiences here is more so in the male bracket. And secondly, what is the risk factor? I mean, are newborn or very old people are at very higher risk?
So male and female, there is a big difference between male and female. So in terms of immune response, the female have higher rates of autoimmune disease, and it's because of the inflammatory response mostly. Because the basic inflammatory response of the female are higher compared to the male. That's why basically they got more autoimmune disease. For the COVID-19, we have no clue actually why the male are more susceptible to the female. It could be also in China, for example. The male are smoking a lot compared to female. So could be not the genetic, could be also the way of life. In terms of young people, I think you know the studies right now. The young people, fortunately, are relatively spared for the disease, and there is different hypotheses which could be also at the same time. So first, the kids have low concentration of the receptor of the disease, the ACE2 receptor in the lung, and also have a higher ECE in the body from they are born to 13 years old. So this is one of the reasons that kids are less susceptible. Also, the immunity of the kids. So at the beginning, the kids have actually inflammatory response much higher, like the female actually, compared to the adults. And also, kids got infected very often with a lot of virus, including coronavirus, because coronavirus, it's a regular disease what we got every year. This trend is dangerous. So because he got infected, maybe all the immunity he developed could have cross reactivity and develop a certain protection for the children.
Okay. Thank you so much for answering these questions. And there are so many, and we have a very limited period of time to be sitting here. Otherwise, it would have been an interactive session for more next 2 hours, because we are also trying to understand and learn this disease as early, I mean, in details or going ahead. So probably to wind up all this thing, I think we are still looking for something called as an how immune are we against this infection, because it is very highly contagious. Yes, there are asymptomatic carriers as well who are having certain type of protective antibodies, and then the plasma therapies and everything is planned accordingly. So probably we are waiting here in to have immune responses and immunity towards this particular infection, and so that we can come out of this lockdown situation and can see each other very well. And herd immunity would be one of an important factor. So that is why we came up with this topic of what is an immunological responses and how we can go into developing an eradication, which is the vaccine, and how today we are only learning prevention is better than cure, rather than we also don't have a very definitive treatment for this particular infection. But hopefully in near future we'll understand this disease more, have a whole genome sequencing done, and then we may go ahead with the immunity, or say we will be having the vaccine towards it. So my dear friends and colleagues, this is what we have to offer you for the next session, which is going to be taken up by an American doctor with a rich year of experience of 25 years. He is Dr. Michael, and he will be talking more, as we today discussed, into immunological aspect. The Dr. Michael is going to talk more on pathological aspect or changes happening with the cytokine storm and its clinical laboratory features, with the clinical trials of the drugs which has been going till date, and we still have to question certain, I mean, there are to be answers to certain questions which are like, why HCQ is working, is there any other treatment, is there a direct treatment or not. So for these matter, stay tuned for the upcoming interesting session again, which will be purely on the pathological role or the pathological changes happening in this particular infection of coronavirus by Dr. Michael. It is on 24th of April. It will be between 5 to 6 p.m. So keep looking, keep staying back, and I am your host for the day and signing off with high gratitude and regards to our Dr. Franck. And also thanking our international marketing director and the team, Mr. Franck Mennechet at HORIBA Medical France division, and the entire France HORIBA team. So thank you so much, Dr. Franck, and thank you so much, the lovely audiences. Every time I see you, probably you might be only listening to my voice, and someday I'll show my face in front of the camera. But currently, I think the speakers and the topics are more important. So thank you so much, and write down your queries or feedbacks and suggestions for Dr. Franck as well as for HORIBA Medical at hematology.hin @ horiba.com. So with this, I take a sign off. Stay home, stay safe, and Jai Hind. Thank you, Dr. Franck. See you again so soon
Thank
with
you.
some. Thank you.
Thank you to you. Bye bye.
Bye bye.